Well, welcome to the online classroom that is going to be a requisite towards your completion of the face-to-face course of the AO North America Pelvic and Acetabular Fracture Symposium. We're going to start our discussion today with the radiographic evaluation of pelvic ring disruption. So what we're going to go through right now and for the next 10 to 15 minutes is a systematic method of evaluating radiographs associated with a patient who might be suspected of a pelvic ring injury. And I want to give you a quick pretest. Here's the scenario. Two brothers were just out joyriding in their grandfather's car, and Kane and Abel show up in your emergency room. These are the trauma AP pelvic radiographs that were obtained from their injury. I want you to take a minute. Now, the luxury of our online pre-course platform is that you can pause. I'd love it if you take a moment, look at the x-rays, write down your thoughts. But for each patient, I want you to think about the following questions. We'll take Kane first. I want you to take a look at it and give me your sense of the quality of the radiograph. And then I want you to look at it and think to yourself, or even write it down, what are the anatomical injuries that this patient has suffered? And finally, after evaluating the radiograph, I want you to tell me what the displacement of the affected portions of the pelvic ring are. So in which direction and what vector of displacement has this patient suffered injury? And we'll do the same thing with Abel. So go ahead and pause at the moment, go back and forth to these two radiographs. In both Kane and Abel's case, what is the quality of the radiograph? What anatomical injuries can you identify? And what is your perception of the displacement of the affected portions of the pelvis? Once you've done that, we're going to go on, and I hope that over the course of the next 10 to 15 minutes, you'll understand at least a systematic method for evaluating the standard radiographic inventory associated with pelvic ring injuries. And the three things that I've trained myself to think about include, number one, the image quality. Number two, I aim to identify the anatomical structures that have been injured. And number three, have an understanding of what displacement is associated with the ring injury. And it's important at this point to take a step back to our anatomy. Remember that the ring, the pelvic ring, is the association of the sacral prominence posteriorly associated with the iliac wings down to the rami, meeting together anteriorly in the symphysis, and that these structures are then held to the osseous anatomy is held together with the very strong ligamentous complexes in the posterior sacroiliac joint region, the posterior hinge, which I'm sure you've heard quite a bit about, and then anteriorly at the symphyseal disc. When a patient has suffered or is suspected of a pelvic ring injury, the standard imaging protocol that we typically follow includes the AP pelvis obtained in the trauma bay, followed by an inlet and outlet radiograph. So these are our orthogonal views of the plane of the pelvic ring. And then pretty much anybody who's gone to the trouble of breaking their pelvis or given the suspicion that they have deserves a high quality CT scan. And in each one of these in each one of the films, we're going to evaluate the film quality, try to identify anatomical injuries, and then do an evaluation of displacement. So first, the AP pelvis. AP pelvis, I think, is a guaranteed or a requisite of any patient suspected of pelvic ring injury who shows up in your emergency room. I think that obtaining high quality images and then interpreting them can be quite challenging. The film quality might be compromised by the patient's positioning with respect to the radiological beam, it can be obstructed by foreign objects, by gas in the colon, by elements that such as debris. There might be a piece of tire left after he's been run over by a truck. Anyway, there are things that can obscure your ability to evaluate the patient's osseous anatomy. So I think the first thing to do is assess the overall quality of the film. And the way that I do that systematically every time, and there are lots of different ways to do every step of this evaluation, your goal is to come up with some kind of systematic method that you're going to use every time. And I'm just going to talk about the way that I do it. When I'm trying to determine what kind of film quality I have or I'm looking at in each one of the radiographs, well, I start by evaluating the patient's lumbosacral junction or the lumbar spine or the lower lumbar junction. and just trying to determine whether or not the patient is rotated with respect to the radiological beam. The next thing I look at is the profile of the the ischial spines. And the ischial spine profile side to side might give me some suspicion, at least, of rotational changes in one side versus the other side. Then I look at the relationship of the patient's coccyx to the symphysis. And I do that, again, trying to determine whether or not there's a positional malrotation of the patient's pelvis with respect to the anterior to posterior beam that's being obtained. The next thing I do is move on to the assessment of anatomical injuries. I want to identify what parts, what osseous structures have been disrupted, or what ligamentous injuries might be suffered as demonstrated by diastases or dislocations of the joints. How I personally do this is go about drawing out the patient's anatomy on their film. And I can do this digitally, or I can print the film out, take a pencil, and do it on a piece of paper that I print out from any printer in the hospital. So going back, when I take a quick look, I just start with the sacrum, and I draw out the sacral ala. I draw out the foramina, which I can see pretty darn clearly. Now here's a piece of bowel gas right there. I can see the coccyx lines, but I draw this all the way down, and I look to see if I can see any kind of fractures in the sacral ala or the foramen. The next thing I'm going to do is the same outlining protocol with the ilium. Starting at the posterior superior iliac spine, I work cranially along the iliac crest. I notice that the film loses it due to the disbursement of the radiographic beam to the anterior superior iliac spine, coming down anteriorly and then following the posterior rim of the acetabulum down to the ischium. I do the pelvic brim. I come all the way down. I outline the entire iliac wing, the pubis, the ischium, the entire innominate bone, and its relationships. And as I do that, if I do it fastidiously every time, I'll pick up fractures and I'll pick up dislocations. One thing to point out is the overlapped experience of the sacrum over the ilium associated with the orientation of the SI joint. So what does that mean? Well, the posterior portion, the posterior third of the iliac wing, proceeds medially to the laterally based sacral ala. That makes a lot more sense looking at the CT scan. If you look at the CT scan and understand that the orientation of the SI joint is rotated externally 30 to 45 degrees depending on the patient, and that the anterior to posterior view of that laterally oriented joint will show the overlap of the sacrum here or the sacrum here on the ilium here, the ilium here. Getting your eye trained to look at that relationship is a really important part of understanding the posterior pelvic ring. A lot of people say, you just can't see the pelvic ring very well in the posterior, and I challenge that. I think we've gotten a little bit lazy with our meticulous nature of reading radiographs. We look at the CT scan. I think if you take a moment, spend 5 minutes with every single x-ray you take, draw out the osseous densities, you'll pick up a lot of injuries. There's a lot of information in this AP pelvis to be had. The last point that I go about, the third point in my systematic evaluation, is trying to come up with an assessment of the displacement associated with the injury. And I think it's relevant to take a step back and think about the different ways in which a pelvic ring can displace. So there are 3 rotations and 3 translations that are possible. Some are more common than others. So the sagittal plane. So we're just gonna, I'm just trying to orient my fingers with respect to my computer here. So if my thumbs are posterior and my fingertips are the symphysis, gosh, that's hard. Okay. The pelvis can rotate in the sagittal plane, and that would be flexion and extension. So flexion with the anterior ring moving cranially while the posterior ring stays relatively intact, and extension to the contrary. Horizontal plane rotation would be internal rotation or external rotation. And frontal plane rotation would be abduction or adduction. Now, we don't see a lot of injuries with an abduction-adduction component to it, But one of the, sorry, getting my hands straight is hard here. But one of the things we can create iatrogenically, imagine if we overcompress the SI joint cranially and open up the inferior joint, we can cause, and commonly do cause, an iatrogenic abduction deformity. So again, sagittal plane flexion extension, medial, lateral, or internal, external rotation, and then abduction, adduction. Translations that can occur. Well, the pelvis can translate posteriorly or anteriorly. If we were looking at an inlet view, it would be posterior or anterior. Horizontal plane rotation would be a medial translation, which is hard to imagine and it doesn't happen very often, but at least we can get some compressive injuries in the sacrum that might lead to some medial translation, but we certainly see lateral translations. And then frontal plane translation, which is quite important, cranial or caudal translation. The trying to come up with a way to evaluate each one of these possible displacements or deformities is important, and this is how I do it. On the AP pelvis, the first thing I'm going to do is drop a plumb line down the center. Then I'm going to place a line that goes from perpendicular to the plumb line and evaluate where the radiological roofs sit. So if one of the radiological roofs is cranially displaced or caudally displaced, the posterior pelvic ring doesn't look to be displaced, so I drop another line at the posterior pelvic ring, that might indicate a flexion extension deformity. So if there's a substantial change in the radiological roofs but no change in the posterior ring, that might indicate a flexion deformity, for example. If both are displaced, so if both the radiological roof and the posterior ilium are displaced with respect to the contralateral side, that might indicate a cranial displacement or translation. So I look for sagittal plane rotations, and I think that's best evaluated on the AP pelvis here. Then I look at the ischial spines and their volume and their profile to indicate any kind of horizontal plane rotation. A different side to side might indicate an internal or external rotational deformity with respect to the contralateral side. Then I look at a translation medial to lateral and I compare from that plumb line to a point designated by my own eye at the apex of the greater sciatic notch or the joining of the greater of the ilium to the sacrum at the most cranial portion of the notch, and I measure it side to side. If y is greater than x, that would indicate to me that the hemipelvis on the left has moved laterally compared to the right. Finally, let's go ahead and see if we can apply this to an example. Systematic evaluation of this patient who shows up in your ER. First of all, quality. What is your assessment of the quality of this image? Well, as I go through my exercise and I draw out the as I draw out the lumbar spine, I see it's a pretty good film. Maybe there's a slight rotation of the patient's axis of the patient's body with respect to the beam, but it's pretty straight on. Then I look at that profile of the ischial spines and I notice that here on the left side, I see a substantially greater amount of ischial spine than the right side, indicating that I'm already starting to think this ilium is externally rotated. I don't think the quality of the film is obscured. I do see this spine pretty good, but I'm looking at that side. And then I draw out the rest of the sacrum and the coccyx as compared to the anterior ring. I'm sure starting to notice something going on here, but it looks like a pretty good quality of film as far as rotation goes. I do notice there are obscuring agents here. I see something that's probably some kind of trauma board. I see the hoops here of the trauma board. But it's a pretty okay film, particularly considering this patient probably had a pretty substantial injury. Second thing I'm going to do is the anatomical injuries. And we've already started the process by drawing out the posterior ring, but I'd go further and look a little bit closer at it. I then go ahead and draw out the iliac wing on the side that looks to be less affected, and when I do so, gosh, it looks pretty darn normal. I'm starting to think maybe that right side is not affected, but when I do the same thing on the left side, the first thing I can't help but notice is this wide displacement of the left ilium, and this large displacement at the symphysis. So I'm looking and seeing anatomically a left SI joint dislocation and a symphyseal dislocation or diastasis. Then the final thing is coming up with some kind of assessment of the displacement associated with this injury. And when I look at that and drop my plumb line, the first thing I notice is that this line, which is hard to see on this x-ray, this line here in the posterior ring, well, gosh, those iliac wings are pretty close to the same height. Distally, however, we see that the radiological roof on the left side is caudal to the contralateral side in appearance, indicating a potential extension deformity associated with the left hemipelvis, at least compared to the right. Then I look at the profile of the ischial spines and see that the left side is greater than the right. I'm starting to think there's an external rotation deformity there. And finally, when I make these two lines, which I'm sorry aren't showing up great, this line from the plumb line to the apex of the notch on one side versus the other, I see it's far greater here, indicating a displacement laterally or a lateral translation. We always supplement with an inlet view. The inlet view oriented towards the patient's feet, looking right down the quote-unquote inlet of the pelvis. This is said to best demonstrate the SI, the sacral ala, the S1 body, the anterior ring morphology, and then horizontal plane rotation or internal-external rotation deformities, as well as axial plane translation. So when I look at that here, we can see if we draw out the posterior pelvic ring, here it looks as though we might have a posterior translation or a change in through the sacrum. As we draw out the iliac wing and then subsequently the anterior ring, we can see compared to the contralateral side, there's no ischial spine profile at all. This is indicating that we've got both an internal rotation deformity as well as a posterior translation of some sort. Finally, in the outlet view, the third view, the radiological beam is oriented towards the patient's head. This is a great x-ray to evaluate better the sacral morphology, the sacral foramen, and this is where we look to cranial translation, reinforce our consideration of sagittal plane rotations that should be, and also look for abduction and adduction. So in this x-ray, if we do our exercise and draw out the sacrum, we can say that there's a fracture through the sacrum on the right side at least, and if we draw that plumb line and measure the iliac height, we can see that the right hemipelvis is elevated cranially with respect to the intact sacral body quite substantially, as drawn here. In this case, however, if we do the same exercise, we see that the posterior ring, looks pretty good. The iliac heights are pretty good, but the patient's hip is higher or more cranial on the left side, indicating that either the left side is flexed or the right side is extended. So that would be more of a sagittal plane rotational deformity picked up. There you go. A CT scan is always done to confirm our plain film analysis. This improves the detection of any posterior ring injuries, which about maybe 20 to 30% are missed on evaluation of the plain films alone. It also gives us a great ability to assess the location of a sacral fracture with respect to the sacral foramina. The other thing to look for on the CT scan is for blush, particularly in the sciatic notch, but in other places, the obturator foramen, for sure another source of arterial bleeding. And some studies suggest that blush on the CT scan indicates an arterial vessel that might be amenable to angiography. Now, this is something we're going to discuss in detail at the course when we have a panel of experts to discussing the role of embolization versus other methods of controlling pelvic hemorrhage. So that, and one last thing to be said about that, maybe at your institution you've seen these volume rendered CT scans, or what's commonly called a ghost image. These ghost images are CT scan data reformatted in a method that's called volume rendering that allows a radiology technician or a radiologist or even the surgeon to manipulate the orientation of the CT data to create a quote-unquote perfect outlet or a perfect inlet to the patient's anatomy, which does differ from patient to patient. Tricks and subtleties, well, when the anterior ring injury is worse than the back and there's multifragmentary involvement of the anterior ring, look for soft tissue injuries in the perineum and look to bladder injuries. So The soft tissues in these cases tend to be terribly disrupted. These are often the result of a crush injury. Anytime I see a terrible injury in the front associated with a fairly mild appearing injury in the back, I look closely in the perineum for open injuries, and I'm very careful to look for any kind of um, urinary injuries. Here's another example of a woman who was crushed by a rock, and you can see virtually nothing going on in the back that we can tell, but look at all this air in her anterior tissues. Another thing to point out here, see these circles? What do you think those circles are? So this patient is in a pelvic binder, and I'm just going to take one moment to say that the pelvic binder can completely distort the orientation of the pelvis and minimize the appearance of displacements, as well as mask soft tissue injuries. It's very critical that you carefully understand whether or not the patient's radiograph was taken bound or not bound as you try to make these evaluations. So let's go back to our patients, Cain and Abel. What did you think? I asked you to take a moment at the beginning of the course. Let me tell you what I think about them. So after my evaluation with Cain, I think it's a pretty high quality film. Anatomically, I've identified an SI joint dislocation here, and there is a massive symphyseal disruption. When I start thinking about the displacement, there's clearly an external rotational deformity. So the posterior column is seen completely here. This looks deformed too. There's looking like there's an SI joint dislocation here as well. This hemipelvis is also externally rotated. But just take a look here. This is the posterior aspect of the sacral ala, and this is the posterior aspect of where that ala should meet on the ilium. And look here, this point of the notch is the same as this point of the notch. And that is supposed to be just caudal to the posterior facet of the inferior portion of the sacrum, which would be here. So this point should be caudal to this. This indicates to me that we also have a cranial deformity. So there's a cranial displacement. It looks like there's a lateral displacement on the patient's left side, an external rotation deformity that's substantial. This is essentially a hemipelvic dislocation on the left side versus the right side. I've got an external rotation deformity for sure, but no cranial displacement, at least that I can tell. We're going to look closer at more films for sure. And in Abel's case, well, my assessment of the quality of Abel's film is that it's not very good. I see a lot of bowel gas. There's rotational deformity. I think this isn't a great quality film, and I'm certainly going to supplement my information obtained or my suppositions made from this film with all the other pieces of radiographic inventory. But I can see his osteology is immature. He has a fracture here in the posterior ilium. I see a disruption in the anterior SI joint. Following this down, there's a fracture in the superior ramus, and I'm suspicious that that's a fracture in the inferior ramus. Now, what I don't know is if there's an external rotation deformity of the contralateral side, but certainly the right hemipelvis is internally rotated compared to the left hemipelvis. So to summarize, I hope that this time has given you a systematic approach to utilize when evaluating the radiographic inventory of a patient who's sustained a pelvic injury. Our routine inventory includes an AP pelvis, an inlet and outlet view, and maybe at your institution those plain films have been replaced by ghost images obtained from the CT-based data, and then a CT scan. My systematic evaluation follows the same profile every time. Image quality, what anatomical injuries have been sustained, and then I try to make some understanding of the displacement of the affected hemipelvis or fragments of the pelvis as best I can, utilizing the methods I taught you. Now, I hope that you'll digest this information because you're going to need to use this as a foundation for not only the next class in the module, which will be pelvic ring classification, but also when you come to the course and work with your experts face to face. You'll have to have a pretty good foundation with this information come into the course. Thank you very much for your time, and I hope you utilize the online platform to go back and review information and take as much time as you need to try to understand this best you possibly can. We'll be at the course ready to answer all questions, and I encourage you to bring them with you. Thank you.